Good afternoon, everyone. Welcome to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. We do this to support an engaged, chosen family, friends, and neighbors who are caring for someone. I'm Felicia Hart, and I will be your moderator for today. We begin today's session by acknowledging the Indigenous peoples of all the lands we are on today. I am coming to you from Clarington, Ontario, which is situated within the traditional and treaty territory of the Mississauga and Chippewa of the Anishinaabeg, known today as the Williams Treaties First Nations. I came to be here through generations of immigration to this land. At the OCO, we are working to better understand how we can be meaningful allies and support the recommendations from the Truth and Reconciliation Commission. If you haven't already, after today's session, I encourage you to learn more about the Indigenous peoples and treaties of the land you live and work on at nativeland.ca in the chat box. So our webinar today is called Caregiving Strategies Supporting Adults Living with Heart Failure. I would like to welcome our speakers for today. We have Dr. Yaz Moyedi, who completed her internal medicine residency, cardiology, and heart failure fellowship in Toronto. She sought to broaden her clinical and research skills and experiences with further training at Stanford University in digital health and precision medicine. She joined the University Health Network Cardiology Division in 2020 as an advanced heart failure cardiologist. We also have Cindy Yip, who is a professional engineer and doctoral graduate from the University of Toronto. As Cindy continues her professional journey to advance patient care, she is also a sole caregiver for her father, living with multiple heart conditions, a passionate patient advocate, a co-founder of Find ACHD, Adult Congenital Heart Disease, and an immigrant. We also have John Udelman, who has been a caregiver to his wife for the past 19 years, now retired with a background in government, NGOs, art, and community organization. He has turned caregiving into a project focusing on caregiver supports and advocacy. So as you can see, we have a wonderful lineup of presenters today. We really look forward to these. So I will now pass it on over to Dr. Moyedi and ask you to please join us on camera. Thank you.
Thank you, Felicia. And thank you for this opportunity. It's really a pleasure to be here. Happy Thursday, everyone. So I've been asked to give you a preamble on the condition of heart failure, and I'd like to start with the definition. So heart failure describes a condition where the heart is unable to meet the body, either because it is too weak or too stiff. And so that's where the terminology of reduced ejection fraction comes from, where the heart is too weak, or preserved ejection fraction comes from, where the heart is too stiff. Heart failure does not mean that the heart has stopped working or is beyond repair. And so this is where language matters. I want you to be aware that in the field, we are starting to move away from the word failure to focus more on function, so that we can communicate that this condition is really not a hopeless condition, and that there are many treatments that are available so that patients can live longer and heart failure is common. It affects nearly 1 million Canadians and close to 30 million people worldwide. So that's nearly all of Canada's population, and that number is continuing to increase. So the advances of heart failure have led to complex medical regimens that are associated with huge challenges for patients to follow. Therefore, and I don't need to mention this on this webinar, but many individuals living with heart failure rely on support from their spouses, partners, family members, friends, neighbors, and other people in the community, which we refer to as the caregiver role. Now, a patient living with heart failure may look at this staircase and just find it daunting to climb. Heart failure is associated with functional limitations, depression, cognitive impairments, and some of the symptoms associated with heart failure are as simple as shortness of breath, particularly with shortness of breath with climbing stairs. And that's how we actually quantify the symptoms of heart failure, as to how many flights of stairs you can actually climb. Symptoms can be associated with swelling, or worsening swelling in the ankles, the lower legs, the abdomen. Oh, sorry, right. I think we're still on that slide. They can be associated with loss of appetite, nausea, feeling confused, dizzy, or lightheaded, and just not able to think clearly. So patients with heart failure need to engage in what we call these self-care behaviors on a daily basis. And that may mean medication management, symptom recognition, monitoring their weights on a daily basis, or adhering to a diet or exercise regimen. But many of these self-care behaviors are just too complex for patients to do independently, which is why the caregiver is so crucial. Now, I wanted to tell you a little bit about the trajectory of heart failure. And this is where we refer to the course of disease over time, from the onset to its progression. Heart failure is very different from the trajectory of cancer, for example, where generally speaking, patients may be stable and then have a rapid decline over months to weeks. The natural history of heart failure often follows a variable trajectory, one that's characterized by alternating periods of stability and instability. And these valleys that you see on the second panel are usually acute episodes of care or hospitalizations. Now, over time, the condition may worsen and patients may become more symptomatic, leading to more frequent hospitalizations and decreased quality of life. Now, with each of these decompensations or valleys, the hope is to regain the previous function, but often patients feel like they never really get back to that initial baseline before the valley. And so the caregiver's role may also change based on these phases of illness. Initially, heart failure may be mild and only cause occasional symptoms such as fatigue or shortness of breath, where the level of care is just related to self-care for symptom management or medication management. With decompensations, so this is where we're referring to hospitalizations, the caregiver may need help with increased symptom management or intensified monitoring or even psychological support. Last thing I was mentioning is that this level of care really changes with these transitions. And as the disease progresses to end stage needs, patients need more help making decisions around advanced planning. So the best way to help someone manage the symptoms of heart failure is to support them through their journey. And this may include encouraging them to eat a healthy diet, limiting salt and sugar in processed foods, as well as eliminating alcohol from their diet, monitoring potassium. Potassium happens to be very important in heart failure, as high or low levels can affect the heart. We also recommend restricting fluids. So patients with heart failure generally should limit their fluid intake to 1.5 to 2 liters a day. And this doesn't just include water. Here we're referring to fluid that's found in fruits, vegetables, soups. So really reiterating the message through education and even sometimes requiring a dietitian consult is required. I wanted to give you some other tips because I think it's important for caregivers to really introduce themselves to the clinicians. Bring a list of questions and concerns appointments. Act as a translator, but also know that if you're not comfortable translating, you can request professional interpreters to help in the healthcare setting. Please feel free to speak up for you or your care recipient if you don't understand what is said. And I think what's really important, particularly as we live in a very multicultural city, is to explain your cultural considerations. So, there are different ways to perceive health and wellness. One of the key roles of the caregiver is to advocate on behalf of the patient and explain these cultural differences, whether it's related to perceptions of medications or diet. So really the care should one size fits all, and one that also respects your cultural considerations. A few practical tips with regards to, financial assistance. If your employment is impacted by your caregiving role, you may require a social worker in your circle of care just to figure out what types of assistance you may be eligible for. It's important to ask your family and friends for help with, potential tasks as driving to appointments, grocery shopping. And, what we've come to understand is that, your family and friends may not know how to help. So communicating specific about what you need may be helpful for the patient, yourself, and your family and friends. Again, get involved with your cardiology team, introduce yourself. Take an active in understanding the condition, the available treatments, and the outcomes. Feel free to ask questions and don't be shy to, look for answers. So I've only given you a very short snapshot of heart failure, the diagnosis, and the treatment. And I apologize for the noise in the background earlier, but there is a ton of resources available in the Heart Hub link that's available to you on the chat box as well. So feel free to visit that website to get more information. And I'm also available for more questions at the end. Thank you.
Thank you very much, Dr. Moietti. We really appreciate you taking the time to walk through heart function, the elements of heart failure as well, and some really practical tips that caregivers can take away today. So thank you for your time. I will now be passing it on over to Cindy. Could you please join us on camera?
Great. Thank you so much, Felicia, for introducing us. And thank you for the opportunity to share my journey about juggling my roles as a caregiver and a working professional and an immigrant. I'm sure my story isn't new or foreign to many of you. And I love to hear your thoughts and your strategy and a bit of learning from you as well in this webinar. Next slide, please. So what's seemingly an ordinary father and daughter photo here is actually a man with a broken heart. And what you're looking at is a very fearful little child. That was me. My father has been living with rheumatic heart disease since he was 7 years old. So you can imagine growing up, I grew up with that disease with him too. He went on with life, got married, and started a family. And I went to high school like everyone else, but one day my father blacked out at work. And next things I know, he was in emergency, he was in ICU. And then the next thing is he needed a heart valve replacement because his valve wasn't working, and he ended up having his first open heart surgery to replace his mitral valve. My mother took care of him for another good 20-something years until she passed away. In early 2021, right in the middle of the pandemic, just to make things even more complicated and stressful, he was once again rushed to the emergency room. And shortly after that, he ended up getting his second open heart surgery to replace his mechanical mitral valve. He now lives with a mitral valve disorder, a dilated aorta, atrial fibrillation, and heart failure. So a relatively typical journey to ending up with heart failure. And I'm sure I'm not alone in this. And over the years, my caregiver duties grows as my father's health evolves. And what I really noticed was the change in my caregiver's duty was so notably increased when my mother passed away and when I became the only sole caregiver for my father. And I hope to speak to some of those challenges and share some of that with you today. And the top 3 that I really want to focus on today is first, I soon find myself juggling many different roles in my life. I was a working professional. I was trying to establish my career and trying to get into any really stable relationship and etc. There was just a lot going on. Secondly, is overcoming the cultural differences it was a real challenge because my father is an immigrant and English isn't his first language and Canada is a new country for him. And thirdly, like many of you out there, navigating the Canadian health ecosystem is never easy. And that really added even more stress. So let me walk you through each of those. So growing up, I had my mindset to fix my father's heart problem. To no surprise, because he had this as he was a kid, and I grew up with him with that. So I was very eager. I graduated from Korean University as one of the few female engineers at the time, a bit of a black sheep. And then I went ahead and obtained my PhD from the University of Toronto, and surprise, specializing in high valve research. Was really, really adamant about wanting a very meaningful career that can fix his problem and advance patient outcome in any way. And that it was so important to me. But as I go through this journey, I also realized with multiple heart issues that my father had, that his health is going to change over time and most likely worsen as he aged, and my caregiving responsibility would increase. And along the way, there will be many unexpected needs. And this meant that relocating for any employment would not be possible or would be very challenging for me. And as a result, I decided against going overseas for a postdoctoral fellowship and professorship, a very atypical path for a PhD graduate. I also anticipated a high likelihood of needing flexibility in my work arrangement, and the ability to work remotely later on in my career as my father's health deteriorated. This meant that the role in a research laboratory, which what I started out my training on, or working in a medical device company, thinking I can come up with something to fix my father's heart valve problem, and where I started my career, wouldn't be suitable for the long run because all these roles require in-person work. So what really helped me to overcome this first challenge is that network very early in my professional journey to explore both traditional and alternative career options, and be willing to take a very holistic look at what are my skills, what are my transferable skills, and how can I apply that in a very creative way to achieve the career goal that I'm interested in. And understand the flexibility early. As I mentioned, I knew at one point I needed a job in a career that can support remote work, so I can offer a webinar like this during my lunch break, during a workday. So how do I tailor that to my career planning goal? And as I start to work and enter the workforce, what I also realized over time is that talk to my employer. Tell them my situation, see what they can do for me, what flexibility they can offer to me as a supportive employer. And ask them what are some of the caregiver benefits that they offer, and if there is any, how can I use them, such as employee assistance program, which has been very helpful to support my mental health. And on top of that, those are all offered as part of your profession, and therefore they are a great resources that are very cost effective, which then reduce your financial burden as you serve as a caregiver. And most importantly, the last message I want to talk about here is really don't give up your career dream, and just be flexible and be able to proactively plan for that meaningful career. Next slide, please. Another thing I have learned is to take care of my mental health. That was something I neglected for a very long time in my career, in the early stage at least. And over time, what I find resources are out there to support you. And one that I want to highlight here is the Workplace Mental Health Playbook offered by CAMH, that are tailored for those who are business-minded, who are business leaders, and who are working professional. And this is a free resource that can help you go through some of those difficult days when you're juggling way too many things, wearing too many hats in your workday and your caregiver days. Next slide, please. My father is an immigrant, as I mentioned earlier, and English isn't his first language. So my second biggest challenge is to overcome these cultural differences. As you have heard earlier in this webinar, ask question. Well, as Asian, we are culturally taught to be humble and always respect the doctors. And that unfortunately means don't ever ask questions, especially don't question the doctors because they're the expert. Don't ask for information unless given and permission to, otherwise you'll perceive as being rude. And always nod so that people know you're polite rather than not because you want to let them know that you understand what you were told. So unfortunately, this also means that a lot of the disease management information get lost when it get passed to my father. And a lot of the time, healthcare teams may mistaken that, oh, he is nodding, therefore he understood us. And that becomes even a bigger problem because then the doctors and the nurses and the healthcare team may misunderstood that, oh, my father is fluent in English, he's nodding, therefore you don't have to be in the appointment, please sit outside and wait for us, because he doesn't seem to have any language barrier. So after each hospital discharge and medical appointments, I became a little detective every single time when I get home, trying to piece together what this different pieces of information he was told and what ultimately his needs are. And at the end of the day, this really translates to a suboptimal care and patient outcome that I can offer him as a caregiver, and also added more stress for me as a caregiver. So, and I know that to overcome the cultural challenge, I know that I need to do something to help the healthcare provider and the whole ecosystem. So what I really end up doing as a coping mechanism or strategy is that I actually speak up, quite opposite to what I'm culturally taught to do, and offer solutions to the caregiver community by working with various groups. So here shown on the right-hand side of the screen, if you can click there, it's one example of working with as a volunteer with the Ted Rogers Center for Heart resource, and put together a patient's resource to speak to some of the tips for non-English speaking patients, so that other people can learn from my experience and be more proactive about how to navigate the situation. Next slide, please. Another strategy I have taken to address and overcome this cultural differences challenge is that I also reach out to different organizations to see how I can help them as a caregiver, and also help them understand what are my burning point, what are my main challenge when it comes to dealing with non-English speaking patients as a caregiver. So here's an example where I had the opportunity to work with Heart Life Foundation, the Chinese Canadian Heart and Brain Health Association, the Canadian Cardiovascular Society, CashNet, and the Canadian Heart Failure Society to deliver a patient resource on COVID-19 in 5 different languages. So I continue to have those dialogue with all these different organizations to offer them translation help or content help or perspective of different cultures, so that when they're developing patient resources, that it's going to be relevant to those who don't speak English as a first language. Next slide, please. The third challenge is navigating the Canadian health ecosystem. All the different trips and hospitals and getting the blood test and connecting to the family doctor and then talking to the specialist and making sure the medication is there at the pharmacy when I need them and correctly prescribed sometimes, and making sure the dentist is aware of my father's special needs because of his complications with his heart. They all add up, and all these trips and communication with various healthcare touch points takes an immense amount of energy, time, and coordination while working in a full-time job. So there were a few things that I found that was quite useful for me. Next slide, please. The first is being able to track his medical notes and results from the hospital, so that I can actually understand what was being communicated and kind of monitor his progression over time. So what I found very useful as a resource was MyChart for those who are in Ontario, because it actually is a one-stop shop for the information that you need whenever your loved one is in the hospital. And that way I can review the medical notes and understand my father's disease management needs, and also prepare question to ask the doctor at each of his medical appointment when the cases where I was allowed to join him in the appointment. Second things that I found was very helpful is how to go about dealing with his complex medication regimen, which is a very typical experience for many of us, as you have heard earlier on in this webinar. And what I found very useful is that when I receive the prescription from the doctor, don't just walk away and nod and say thank you, but also ask the doctor, when I need the renewal for this prescription, who is going to be responsible for it? Is it the family doctor? Is it the dentist? Is it the cardiologist? Or is it some other specialist like the dietitians? And that way, that really helped me prepared when his prescription is running out and I need to ask for a renewal. And that's also helped smooth out the communication between the pharmacist, myself, my father, and all its different doctors that are involved in his care journey. And lastly, one thing that I have leaned on a lot is technology. So I start using an app from a pharmacy so that I can manage all his prescriptions. So I know when his prescription need to be refilled, when to be renewed, and also manage the payment remotely so that I can do that during break time at work, and also set up notification with this app so that it will prompt me when the medication is actually ready to pick up, so I can plan my commute between work, grocery store, pharmacies, home, and various appointments. So that was a big time saving for me. And lastly, I know my journey, as I say, is not new, nor is it unique. So what I keep in my mind that helped me stay calm along the way and help me stay systematic and logical, is by knowing I'm not alone. And I think that message is always there to prompt me in my little head so that you can ground me, and it's really helped me focus on what I need to do best is to care for myself and my father. And with that, I want to leave you with a little bit of resource that I found was very useful and very trustworthy. And I do say trustworthy is very important because there's so many information out there, and that sometimes can be a cause of stress for caregiver trying to find useful information to make our life a little bit easier. So some of this example here, as I mentioned earlier on in the webinar, the Heart Hub have a lot of information. If you want to learn more about my story, feel free to go there and read a little bit about my story, but also learn from other caregiver story and their strategies. And another place is the HeartLife Foundation, which is a patient-led organization, and you can find useful information there as well, such as the Canadian Heart Failure Patient and Caregiver Chatters. I think that is a very helpful resource to understand what are my rights as caregiver, so that you can be part of that care journey with your loved one. And I would say the last thing, the third thing here highlighted in the lower left corner of this slide is technologies. There are many useful technology out there that may either give you useful information in a one-stop shop manner like MyChart, or connect you with other in the heart failure community so that you know you're not alone, such as the My Heart Failure apps, or help you monitor your heart health, such as the Medley app shown here. So don't forget, if I were to leave you with one message is, don't forget all this trusted resource and support you have. And also don't forget the resource that's available in the Ontario Caregiver Organization as well. So thank you so much. And with that, I will pass it back to you, Felicia.
Cindy, thank you for sharing your personal caregiving story with us. I thought it was so wonderful to hear about how your career goal was really to see how you could help your father. I think that was so incredibly touching. You also really outlined some key challenges that I think a lot of caregivers can relate to, but then also some solutions you've been able to find. So incredibly helpful. Thank you again. So John, it's now time for your presentation. I'd like to invite you to join us on camera, please. And then I'll be over to you.
Thank you, Felicia, and thank you, Yas and Cindy. Really appreciated hearing your presentations. I think I'm going to be trying to make use of them a bit as well. And just to tell you a little bit about myself, I've been married for 36 years, and I have two adult daughters. One's launching her career, and the other lives overseas. I live in the shadow of 3 or 4 major Ontario specialist hospitals in Toronto, which is great for specialist care, but it actually is terrible for trying to connect to the local communities in the area. The journey has been really a multi-sickness journey, starting with lupus and involving osteoporosis and heart valve issues, and now heart failure and multi-organ issues. The current status is probably the stiff heart, so the heart failure with preserved ejection fraction. There's a group 2 pulmonary hypertension diagnosis. We're at stage 3 or possibly 4 of chronic kidney disease. There's diuretic resistance, which means the medicines that one takes often to manage the symptoms of heart failure aren't working as well. We have daily hospital-based monitoring, and we've had 2 or 3 what you might call our exuberances. I would say in terms of Yas's trajectory, we're probably somewhere towards the end, somewhere between what is labeled care transitions and end of life. So I would like to, if I can talk a little bit, and I'll try and be as fast as I can, because I think the most important thing is to hear other caregiver questions. But I'm just going to briefly talk about my experience, some observations and lessons and tips I've had. So the first one is really discovering that the stiff heart is really a terminal multi-organ condition. And it's a particular kind of condition that has no available prognosis. In other words, we keep getting told there's no statistics to kind of tell you where it's going. Where that leaves me is kind of in this situation, and my wife in the situation of radical uncertainty. If you looked at the cancer trajectory, at least you would know kind of where things are going. We don't know where things are going. So you have to hold in place the idea that you're living a normal existence. You're somewhere in this, entering this palliative gray zone, whatever that means for heart failure, which isn't the same as what it means for cancer, and the idea that there's a terminal condition altogether at the same time. There's lots of tensions, ambivalences like hope and despair, or holding on, letting go, and that bounces you all over, and it bounces other people all over, including the medical system. In my journey, I've discovered that underneath the medical system and the circle of care and everything else, there's sort of lots of values and strong feelings about what it means to be a family, or what sickness means, or what death means. And all this really boils down to, you kind of got a downward slope. There's a chart in the appendix that kind of speaks to the caregiver journey. But each time you hit something, it's kind of reformulates. You have to kind of reformulate who you are, and your spouse has to as well. And that in itself becomes a big stress. What I would say is the management of the issue, which I think Cindy spoke eloquently to, is difficult. There's no denying that. But I would say the hardest part I've found is actually what I call ethical dilemmas, like decisions about what to do in terms of trade-offs or how to handle it, the uncertainty. Next slide. So my main observations are, in my journey anyway, to try and get community resources or deal with things from that perspective. Like you can only really generate that when you have, you tax the hospital system, or you're in emergency rooms. That's, you've been in a situation and you've got this, the system doesn't respond from a resource perspective to support caregivers unless there's really a crisis. The second major learning, I would say, is there's a lot on education out there about salts and fluids. But the next level, which is, okay, I've taken the scale course. I'd like to be able to talk to other people in a similar situation. There are really, so far, at the Ted Rogers and the Women's College and most of the hospitals, there's no acute heart failure support groups. There's no social workers supporting caregivers. The Medley doesn't have a social worker associated with it. When you get to the palliative period, there's a lot of discussion about goals of care for the patients. It's very patient focused, but there's no goals of care for the caregiver. And there's basically no model of shared decision making. We are effectively running what I would argue is a complex care bed in the home setting. We have Medley, we have a lot of blood lab work being done here, but it's the hospital systems that are a big part of my life don't really, are all focused on the patient, don't take account of the fact that I live with the patients. Take care. Next slide. So I'm just going to briefly talk about some of the things I've learned. So the main thing I've learned is you kind of got to make your household into kind of it's normally a relational place. You know, you have daughters and husbands and wives, but it's being matched up against a very large healthcare corporation. The corporation is kind of a urgent place where things happen, and it has a clear come on down style. You know, talking about your sister or your brother or your wife, that's more about the relational style. But to make it work, you kind of have to turn yourself somewhat into a small family corporation. So the first thing I would say is I don't think the government really is working on the family needs or the couple needs. So my tip here would be the first question one asks is it going to be the couple or the wider care family making the decision making? I think Cindy spoke to this a bit. There's another question that one has to answer is about how you're going to communicate to the greater group, because if you don't communicate, then they're saying you never told them. But if you do communicate, they might not feel still that they're being heard. I would recommend, at least at the beginning, if you're in a couple situation, there's a lot of relational tensions involved. I would recommend getting someone to help with that as soon as possible. I think it's very helpful through the journey because, as I said, the couple's identities keep changing. If you don't have a spouse or a child, my recommendation is that one try and find a private independent case manager, start having at least a meeting with them, and they effectively might be able to accompany you through some of this stuff. On the other side, I would say you need to recognize heart failure as a multi-organ thing. It's not just about hearts, it's about kidneys and other things. So I think as a navigator and an advocate, you should be trying to get other specialists like a nephrologist or a dietitian on the team. I found in my research 2 sites that I thought were significantly were good and reliable and provide more information than can be found in the current Canadian sites. One is the British Heart Failure Society site, which gives much more information about the trajectory all the way to the end. And if you're looking from the end back, the Canadian Virtual Hospice site's pretty good. I'd like Cindy think learning everything you can is useful. When you're at home, I think some of the things I've done is I've actually commissioned a nursing report from another healthcare agency to try and argue with home care about the level of care needed. I've set up in the home setting an idea. I think physical activity, as Yas mentioned, is pretty critical, both from a heart muscle perspective, but also if you're suffering from fatigue, it's one of the few things that probably can help manage the symptom of fatigue. So trying to get a yoga instructor or someone to come in. When I'm trying to deal with the advocacy end, some of the things I've learned is there is a patient relations office inside a major health facility who is available if you're having difficulty. The big thing is to try and find a partner to work with, because the system is the system and it's difficult for everyone. If you can get that. I have considered, there's a secret thing in home care services called family managed care. It's kind of an exception, but it's one that people who have complex care conditions, particularly children and their parents, use, which allows you to get the home care resources in the form of money, and then you manage that process yourself. The only spousal piece I've been able to find directly is the Well Spouse Association, which is a self-help group that operates in Zoom out of America. Next slide. Okay, so here's some of the nitty-gritty. Incontinence is a major issue. It's a side effect of the treatment. And it's was one of our kind of more embarrassing kind of transitions. The treatment also often causes gout, I should say. So one place I found helpful was to go to this physiotherapists that are called pelvic physiotherapists, so who are good on incontinence issues. Second thing is, as I pointed out, is ER and the hospital are realistically the only time that the home care system is going to pay attention and try it. I've taken a position that every time there is a hospital stay or whatever, I try and leverage that avenue. So I go and try and, even if it's in the ER room, I try and find a hospital social worker to speak to. If it's in the hospital, I have had to deal with, there's a lot of pressure on the hospitals and where we're going to send you. I tell the attending physician, I make a point of telling them that I would like to have a position of medical stability. The issue of being sent on when you're still in pain and everything else and being left with is a problem I've encountered. Money, that's a big issue. I think it's been alluded to. One of the ones that I've worked on is between us trying to create a notion of how much money would be needed for me, that's the second person after my wife's passed away, for my care. So trying to create a point where at least the red flags go off, that we're not all spending everything on one end or the other, trying to create a balance. I've made a lot of use, and I'm happy to talk about CRA disability and tax credits, accessing health benefits in retirement, making use of EAP as a retiree. COVID's come along, so that's been a big issue. That's sort of been another layer. Right now, there is no infection control in home care services, so very minimal. So I've tried to go with the standard. Obviously, if you have heart failure and lupus, COVID's going to be pretty significant. So we've moved to using N95s inside. I've got a CO2 monitor, which is a quick way of checking if there's enough air ventilation. They're online, and if you have a reading of 800 or less, you're fine. If you're 800 to 1500, you better be careful. Above 1500, you know you have a problem. I've tried to use workers that work in the long-term care, although I know it's a risk, but at least they have infection control there. I try and find people who are working with organ transplant people, because they're sensitive to the issues of COVID and heart failure. Next. Palliative care, which is the part that most of us probably aren't as familiar. I would just say don't leap into it too quickly. And you've got to do a lot of differentiation. And the idea that you can get help to stay at home is unfortunately not available right now. There's not nurses, and there's a significant shortage, so you're going to have to rely a lot on family and friends. Within the palliative system, the key feature is that who is the power of care. That person holds some advocacy position. Be aware that a lot of long-term care homes don't have palliative care. In the hospital, like the patient relations person, there are bioethicists that can help you. And where the ambulance goes is really critical at this point, because the different hospital systems have access to different facilities. Okay. Thank you. Just to point out at the end, there's some slide illustrations of some of these points.
Thank you so much, John, for sharing your experience that you and your wife have been through. You really did a nice job of outlining all the different challenges that you face, but then some things you can do about it. And it seems like you've learned so much through this and have a wealth of knowledge to share with everyone. So we really can't thank you enough. Thank you to all of our presenters. A few people have shared some questions, and I will please ask that our presenters join me back on the screen. And I'll go through some of the questions that came forward. So you can keep them on coming in here, and I'll work that out to make sure they can be asked to our presenters. One thing that came forward was one of our audience members said that she is caring for her mother, who has had 3 episodes of heart failure and subsequent hospitalization. She is looking for recommendations on diet, patient handling techniques, like helping her stand up, lay down, even some massage points or a workout regimen, something along those lines. Now, I feel like this question could be to any of you, actually, but I'm wondering if maybe we might start with Dr. Moyedi. I know that you mentioned some ideas for who to reach out to if people do have a contact in hospital. Do you have some ideas of who else could help with that?
Yeah, so an incredible resource for heart failure is we make referrals to rehab. And so there's definitely benefits to going to in that. There is an exercise physiologist. There is potentially a physiotherapist. Sometimes there's a dietitian in the circle of care. And with COVID, we've seen that centers have become adaptive as well. So they do these sessions virtually. So some advice can be gathered from a referral to rehab. While in hospital, if the care recipient was seen by a physiotherapist or an occupational therapist, these allied health doctors can also make recommendations for home. And through home care, they do have some alliances to provide some care at the home setting. So probably the most important resource, and then have been hospitalizations, then tapping into the physiotherapy and occupational therapy resources is an important one.
Thank you so much for that. John and Cindy, did you have anything to add?
If I can, I think the route we've actually used is there's community health centers in many parts of Ontario, and there's often a diabetes education group in them that have dietitians, and that's kind of so. A lot of the time, there's a kind of pre-diabetic condition associated with some of these heart failure situations. So that's been one of the avenues that we found very useful to get sort of every 6 weeks engagement.
Nice, thank you. Cindy, did you have any other further comments?
I agree with what John and Dr. Moyedi have mentioned. I think when it comes to getting home care or rehab or referral, it's important to also make sure that as a caregiver, let the doctor know there may be, because of your culture, for example, for my father, he wasn't open about having anyone entering his home. Home is a very private place for the Asian culture for us, right? And just making sure the doctor knows so that the healthcare team push and articulate the importance of that, so that then the caregiver can spend the effort to then speak to the importance and just keep reiterating that message to overcome that cultural beliefs that I don't want anyone in my home, I don't need rehab, I'm a strong alpha male, I take care of my family, right? To overcome that cultural barrier.
Thank you. Definitely some considerations to keep in mind for sure. So some other questions here we have is one of our participants is asking if you could explain preserved ejection fraction. That was mentioned at some point.
Yeah, so I can feel that one, and I'm sure John could speak to his experiences as well. But so with the classification of heart failure, we divide heart failure into a weak muscle, so heart failure with reduced ejection fraction, and then the opposite is where the actual muscle is okay, but the heart stiff. And the reason we divide heart failure into those two classifications is because the treatments are different. And so when we refer to the weak muscle, there are 4 classes of medications that we prescribe, whereas in the stiff heart, we're only starting to now see medications that are potentially effective in the treatment of heart failure with preserved ejection fraction. So the reason for the classification is really because of treatment. And then when you talk about the different causes of heart failure, that results in a list of different reasons why the heart is either stiff or weak. Does that explain things?
Yeah, I think that really helps. Thank you. I know there were a couple questions on that, so that's perfect. The next question, it's actually more of a comment. There were a few comments in about how people are having a really hard time finding that financial support for the person that they care for and for themselves. So we know that that can be a huge challenge, and we did talk about that a little bit already. The one thing that came forward, though, is that they're finding that heart failure stage 3 isn't recognized as a disability. And so they're having a really hard time working through the system. Now, we do have a CRA webinar coming up later this month. So maybe that's something that we can, provide more information on there. But I know, John, specifically, you did talk about some ideas that you had for making your way through a bit of that system. If there's just like even one main tip that you could suggest, and this is something that we can look at for a later webinar as well.
So to get the disability credit, there's a special form the doctor has to fill in, which is basically about functional disabilities, not about medical disabilities. The main trick there is at the back, there's a place you can say, even though you don't, you can still walk or you can still toilet or shower. But it's together, they're enough to make it a functional disability. There's a box at the back that kind of the doctor can use to build a case where there's partial things going on, but that you actually qualify. So that's a tip there. Okay.
Thank you. That's super helpful. And I will.
It may be helpful to clarify that we don't really have a stage 3 of 4 class in terms of how symptomatic patients can be. So what John was alluding to with the functional limitations. And so that's really bringing to the classic Heart Association classification system. So class 1 patients aren't symptomatic at all, and B is where patients are significantly more symptomatic, where they can't do that 2 flights of stairs that I was referring to in my slide set. So the more symptomatic a patient, the higher the class functional limitation.
Thank you again. That's great. I'm just going to squeeze in one more question before we start to wrap up, because we do have another minute or so. But there is a question about how strict do you really have to be with those fluids? And I know you said the amounts earlier today, but the other part of the question is, what is normal when it comes to weight gain, weight loss day to day? Is there a range that's pretty acceptable there?
We generally we recommend less than 2 liters a day. If we're going to be really strict, it's 1.5 liters. And sorry, Felicia, what was the second part of that question?
Yeah, they were just asking if there's a normal range for weight gain or weight loss day to day.
Yeah, perfect. So generally we say that, within 24 hours, your weight should not go up by 3 pounds. If your weight 3 pounds, that's fluid. And so, if you're in a platform like Medly, you'll have clear recommendations as to what to do if your weight go up in that 20 period. So the general rule of thumb is 3 pounds in 24 hours.
Great. That's super helpful. I think it definitely gives people a range to look out for. So we are at the end of our Q&A. I just end the end of our webinar.